Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
A quick reminder before we begin, you can always send us your questions for Dr. Mingle on LinkedIn or YouTube, or in an email, send it to hello@minglehealth.com. Okay, we have 3 great questions for you today, Dr. Mingle. Are you ready?
Bring them on, Kyle.
Our first question for you today is from Kristin, and Kristin asks, many of my clients are participants in an advanced alternative payment model, like the Medicare Shared Savings Program. Many of them continue to make MIPS submissions just in case. Is there any value in that?
Great question, Kristin. There is some potential value, and it relates to QP status. QP means qualified participant. It's not enough to participate in an APM. You have to hit thresholds of either the percentage of Medicare beneficiaries or the percentage of Medicare billings that get attributed to your providers through the APM to be a QP. If a provider, by hitting those thresholds, becomes a QP, MIPS submission is entirely unnecessary. If they hit a lower threshold and become a partial QP, they can elect to participate in MIPS or not, and if they're neither partial nor a full QP, they have a MIPS liability. If they don't make any MIPS submission or no submission is made on their behalf in a year in which they're neither a QP nor a partial QP, they might get a maximally negative MIPS adjustment if they have not made any MIPS submission. Now, the details differ for different APMs. All APMs, that is advanced alternative payment models, are required to be subject to some kind of quality analysis. In the MSSP, the most common APM, that is the Medicare Shared Savings Program, the APP, that is the APM performance pathway, is required by the APM, by the MSSP, to collect any shared savings that are generated. Now, for the APP in that MSSP, the APP serves not only as a quality submission for the MSSP, but it also serves as a MIPS submission for participants who need one. Now, that's not necessarily the case with quality reporting required in other APMs. So pay very close attention to the requirements in the APM in which the provider is participating. So a MIPS submission for your providers who are in APPs can be a wise precaution. I'll give you three reasons for that. If they do not make QP status, they might need a MIPS submission to prevent a deep MIPS penalty. 2, we've come across some APMs that fail to submit their quality reports. If your provider is counting on the APP submission to count as their MIPS quality submission, they are completely out of luck if the ACO does not submit. And finally, if they do require a MIPS score, they might just generate a better score on their own than the ACO generates. After all, the ACO report is going to average essentially the performance of all the providers in the ACO. If your provider happens to be a top performer, their individual MIPS submission might be better than the ACO score. So they could end up getting a better adjustment on their own than being subject to the ACO score. And Medicare will give them credit for the highest score that is submitted on their behalf.
Our next question for you today, Dr. Mingle, is from Lisa. And Lisa asks, in the QP, that is Qualified Participant Lookup Tool on qpp.cms.gov, I read, 2024, the clinician will receive a physician fee schedule update on services furnished in the payment year based on the 0.75% qualifying APM conversion factor. Voluntary reporting won't affect this. What exactly does this mean? And is there any benefit to reporting?
Great question, Lisa. It's a confusing statement on more than one level. First, what does it mean voluntary reporting won't affect this? Second, does 2024 refer to the performance year or the payment year? And third, it's an incomplete description of the true incentive offered for the 2024 performance or the 2026 payment year. Now, to orient everyone, this refers to Advanced Alternative Payment Models, that is APMs. There's a threshold measurement of your patients who are attributed to you in an APM. If you exceed that threshold, you're considered a qualified participant in that APM. Medicare offers an incentive for providers who become QPs. This statement refers to that incentive for that QP status year by year. Now, first, let's tackle the statement voluntary reporting won't affect this. It basically means that the incentive is for being a QP. It does not depend in any way on reporting. You don't need to make a MIPS report to earn it. You don't need an APP quality report to earn it. If your quality score is low, you'll still be awarded the incentive. It makes no difference if your ACO, if your APPM generated shared savings or not. It doesn't matter if they earned those shared savings to collect those shared savings or not. So it is completely divorced from any reporting. It's just an incentive for being a qualified participant. And it is in addition to whatever rewards come from the APM. Second, the statement is confusing in that it's unclear whether it's referring to the performance or payment year. In the context, I know this statement refers to the 2024 performance year. If you become a QP for the 2024 performance year, you'll receive higher reimbursement on your Medicare claims in the 2026 payment year. Now, Medicare payments are made based on the physician fee schedule that Medicare updates every year. It is based on a series of resource-based value units, or RVUs. After adding up the RVUs for your billed CPT code or codes, the RVU value is multiplied by a conversion factor to come up with the allowable amount for reimbursement. Every year, that conversion factor increases by 0.25% for the generally for the providers who are billing Medicare. But for QPs, for the very first time for the 2026 payment year, their conversion factor will go up by 0.75% instead of the standard 0.25%, giving each QP better payment than everyone else gets for equivalent service. The 2024 performance year for the 2026 payment year is the first time that the QP gets this type of incentive payment. This favorable conversion factor is expected to continue indefinitely. There's no end date set on it. Of course, it's liable for all the changes in legislation and all the changes in the rules that we know can happen from year to year. Now, finally, the statement is oversimplifying the QP incentive, particularly for the 2024 performance year and the 2026 payment year. The program started with an annual 5% lump sum payment for being a qualified participant, or a QP. You became a QP in the performance year. That first performance year was 2017. 2018, the year after the performance year, was the base year. 2019, 2 years after the performance year, was the payment year. Each QP established in the performance year of 2017 was paid 5% of the base year eligible Medicare allowable charges in a lump sum in the payment year of 2019. So pay attention to that sequence. It's performance year, base year, payment year. Now, the 5% lump sum incentive sunset after the 2022 performance year, meaning that the last 5% lump sum incentive is or was paid in 2024. Of note, I'm recording this in 2024, so I'm talking about this year that I am sitting in right now. Medicare added a 3.5% lump sum payment for APM participants who became QPs in 2023. That 3.5% lump sum payment will be paid to 2023 QPs in 2025, and that incentive will be based on the base year, that is this 2024 year, billings. Now, the 2024 performance year that I am in now became more interesting in March of 2024 when a minibus appropriations package passed by Congress and signed into law on March 9th added a 1.88% lump sum payment in 2026 for APM participants who became QPs in this year, 2024. That 1.88% additional lump sum is in addition to the favorable conversion factor that was already scheduled to be paid to get started in this performance payment year dyad. That is, for qualified participants who became qualified participants in 2024, they will benefit both from that new 1.88% lump sum payment as well as the favorable conversion factor in the payment year of 2026. Now, it seems simple, but there is some ambiguous and even contradictory guidance out there, and does not all seem to be documented as carefully in the Electronic Code of Federal Regulations, that's the eCFR, as what is customary. Now, in review, I'm recording this in 2024. APM participants who became qualified participants in 2022 have received or will be receiving the last 5% lump sum incentive calculated on their 2023 allowable Medicare charges. Now, this year, 2024, is the base year for APM participants who became QPs in 2023. They will get a lump sum incentive payment in 2025, that is next year, based on this 2024 year's Medicare allowable charges. Now, APM participants in this 2024 performance year will get a 1.88% lump sum incentive in 2026 based on Medicare allowable charges in 2025, and they will also get higher payments for all of their 2026 patient services. Now, after this 2024 performance year, 2026 payment year, we expect to see no more lump sum incentive payments. We're expecting to continually see a higher payment for Medicare payment year services based on a higher QP specific conversion factor in the physician fee schedule. Of course, that can all change with one legislative cycle or one rulemaking cycle, but that's the way it looks today.
And our final question for you today, Dr. Mingle, is from Glenn. And Glenn asks, I'm worried. Medicare has this digital strategy, and they've proposed to discontinue MIPS CQMs for the APM performance pathway, that is the APP. It seems like the writing is on the wall, and one of these days, eCQMs will be our only choice. How are we going to make that transition? It seems insurmountable.
Great question, Glenn. Now, I still prefer MIPS CQMs to eCQMs, but whatever direction CMS takes, we can help you deal with it. We can do it together. Now, the primary goal with any quality reporting program is to report your clinical quality performance accurately and efficiently. It has to meet, no matter what method you use, it has to meet that standard that you and I attest to every year. It's complete and accurate to the best of our ability. It can be done with MIPS CQMs, eCQMs, Medicare CQMs, or anything else that Medicare might dream of. Now, Medicare CQMs, we expect to be temporary. Medicare wants us on all patient, all payer reporting, and that's just not Medicare CQMs. Eventually, they will end this in favor of one or more all patient, all payer methods. Now, when it comes to MIPS CQMs and eCQMs, Medicare also wants to get us to all electronic reporting. Many people don't realize that could mean either, but it can be either MIPS CQMs or eCQMs. Now, eCQMs can't be anything else but all electronic. Nothing else passes as an eCQM. So most people consider eCQMs as synonymous with digital reporting, but you can do MIPS CQMs as all electronic. Most of at least our bigger submissions for bigger practices are based on electronic data. Some are entirely electronic, but some are supplemented by other data sources. And at Mingle, we've done a lot of all electronic MIPS CQM reporting. In the first few years of MIPS, you may remember there was a bonus for all electronic reporting. We earned that incentive for many of our clients using MIPS CQM reporting in an all electronic fashion. Now, let's compare and contrast. There's similarities, there are differences between eCQMs and MIPS CQMs. Now, the specifications in format are different. The eCQMs are written in technical language and refer to standard code sets, specific standard codes, and collections of those codes called value sets. Now, Medicare CQM specifications are written in standard language. When it refers to codes, it only refers to the two code sets that are reliably standardized in everyday use by all of us. And those two sets are, first, current procedural terminology, that is American Medical Association CPT code set, or the International Classification of Disease codes, currently ICD-10 codes, that are sourced from the World Health Organization and modified by the U.S. Center for Disease Control for use in the United States. But the two sets of specifications mean pretty much the same thing. In the past, there were some major differences between eCQM specs and MIPS specs, but in recent years, they've been converging, and accounting for the difference in language, they really mean it's the same care they're watching for, the same restrictions, the same filtering, the same exclusions. Now, any data that can be used to create an eCQM can be used to create a MIPS CQM. It includes QRDA, that is QRDA1, HL7 messages of any CDA type. CDA is clinical data architecture. QRDA is one version of CDA. There are many others. And a lot of people don't realize, but eCQMs don't require QRDA. If you have someone doing eCQMs for you that's not an EHR, even your EHR, if they're creating an eCQM for you, they don't have to deal with QRDA. It can use direct extracts from the EHR. To be certified, you have to be able to read, you have to be able to write QRDA. It's a standard way to exchange data, but as long as it's electronic, it is usable in your for your eCQMs. Now, the reverse is not true. Many data sources that can be used to create a MIPS CQM cannot be used to create an eCQM. eCQM destined data has to be collected by and recovered from certified EHR technology. MIPS CQM destined data can be electronically sourced, but can also be manually abstracted from a paper source or manually extracted from an EHR, and can be derived from a secondary electronic source, like an immunization log, a tumor registry, or other specific disease or treatment registries. Each code set exists as a standard and calls for standard usage, but they are redundant and overlapping, and no single standard is agreed upon or required. And the National Library of Medicine lists and tracks 105 standard code sets and offers translational tools for many. It is just as valid, however, to use your own locally grown code set, and most people are creating locally grown code sets. It's called the English language. You're making entries into fields using the text blocks that you choose to put there. Now, if it's free text, it's very hard to query, very hard to measure. If it's structured text, so you're always putting the same entry in under the same circumstances, those are much easier to translate and to translate to the other more standardized languages. Now, there are not as many measures available in eCQMs as in MIPS CQMs. Now, Medicare doesn't create or maintain measures. Medicare sets the standards, judges the various measure candidates submitted by experts and expert organizations, and maintains a library of applicable and acceptable measures. Now, it must be easier to author and maintain MIPS CQM specs than eCQM specs, judging from the current availability and the annual turnover of measures. Much more turnover in MIPS than there is in eCQMs. And that's another reason why we should not be overly quick to eliminate MIPS CQMs for eCQMs. So, without all that under our belt, and now that you're an expert in the differences, let's talk about the process of switching from MIPS CQMs to eCQM. What you should do and what you should not do. Now, I recommend that your analysis and reporting process every year includes a layer of data validation, and that's whether you're using eCQMs or MIPS CQMs. You should take a modest-sized sample of data from the analysis and manually compare to the charts to be sure your performance analysis is accurate. You should take 10 or 20 examples of performance met and be sure that you can find the chart entries that define met performance for that measure. You take 10 to 20 examples of performance not met and look for data that should have made it met. In those cases where your chart audit or data validation shows that the analysis was not accurate, you will launch 2 additional actions. One, you'll want to look for the error in the data flow. Somewhere your queries are not picking up the data or not passing on to the analysis process. So determine and correct the reason the right data was not reflected in your analysis and get it fixed for future years. Now, you'll also want to correct your report to reflect a higher earned score. You're never going to get quite as good a score from an all electronic process when you supplement it with a data audit step to find errors and correct them. If you want to get your best score, you'll take a complete list of all your performance not met instances, and you'll manually audit the chart for data and correct it when you find performance met data. Now, this pertains to eCQMs and MIPS CQMs equally. The only thing that differs is your options for correcting this year's score. When you discover a correct discrepancy, I suggest you expand your data validation to include all patients who don't meet performance, do an audit, and correct just those. It's an interesting, if you look across all measures, you'll find that missing data is typically always a performance not met situation. And so if you don't pick up the data, you're creating a not met count. When you find data, it's virtually always improving your score. You don't find negative data. You either find data or you don't. And when you find data, you are finding a higher earned score. So in MIPS CQMs, you can take the results of that final audit of performance not met instances, and you can just turn that in as an Excel spreadsheet to us to correct or update your data. Now, it's usually in an Excel spreadsheet. We can use that to correct your MIPS CQM data. You don't have to correct the data in your EHR. It pays to retrain your providers to record it in the right place that it can be found, or it pays to expand your queries so you find it in these other places. Those things are great work to make it easier year by year and get your scores higher with less work. Now, if you're doing eCQMs, you can correct those as well, but it has to be a corrective entry in the EHR. I'd empower my support staff to take data found in one format and re-enter it in the format in which it can be found by your reporting process, and then rerun and resubmit your new data. That's basically the biggest change in workflow in changing from MIPS CQMs to eCQMs. And it's simply a matter of taking all the efforts you're already making to do MIPS CQMs and just turning off the manual pieces. Do all your corrections electronically, submit new data, run the new analysis. One other error I see commonly made in eCQM projects is to invest too much in infrastructure. It comes down to 2 expensive recommendations that you don't have to take. One is an Enterprise Master Patient Index, commonly known as an EMPI, and the other is a Central Data Repository. Now, the Enterprise Master Patient Index takes the patient lists from each of your component systems, and it compares more than just the first name, last name, middle name, date of birth. It also looks at phone numbers, addresses, old addresses, basically any data that's in your EHR or practice management system is game to be involved in that. So it can identify patients whose first names entered differently into systems, who's changed their last names, who changed addresses. It takes all the data, compares it, and gives a numerical score that tells you how likely this is to be the same patient. Central data repositories takes data that exists in all these different systems and translates it into a single common standard language and keeps it in one area so you can draw upon it when you need it. Now, both are great tools with a lot of potential value, particularly if you are actively sharing and using EHR data at the point and time of care every day. But it's serious overkill, that is overspending, if the sole purpose is quality reporting. A good EMPI and a good data repository with solid processes around them can get you to 6 sigma error rates, very low error rates. But the limit of Medicare's comparison between practices on which it bases MIPS scores, on which it bases collection of your shared savings for MSSPs, generally is nearer the 3 sigma level. And it goes out to 2 decimals at most beyond the decile rank. We can get to that level of discernment from data that is typically native to your CEHRT systems without using an EMPI or central data repository. The monumental expense involved in implementing and using that EMPI and central data repository involve purchasing the necessary hardware, licensing the necessary software, and putting a team in place to work the errors every day. And that's key. It takes constant work to take those reports of patients that may or may not match and make a judgment that they do or don't. It takes constant work to make sure that data combines and any errors in the data entry from one system is corrected and brings everything together accurately. So save that expense and effort for when you will use it to increase the value of your care to your patients. You don't need that level of discernment to measure the value of your care for Medicare.
Thank you, Glenn, for the great question, and thank you to Lisa and Kristin as well, and thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you for the great questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.